Welcome back to the New York State Department of Health Clinical Education Initiative's Building Blocks for Trans and Gender Diverse Care series. My name is Erica Bostic, my pronouns are she and her, and I'm an adolescent medicine physician and faculty for CEI Sexual Health Center of Excellence.
And I'm Kai, my pronouns are he, him, and I'm a clinical educator for CEI. And in this video, we'll be covering what medications are used as part of a feminizing regimen, how to prescribe and monitor these regimens, what the expected changes are for individuals undergoing this regimen, how long it takes to get those changes, what the common side effects are that you should be on the lookout for, as well as some frequently asked questions that patients might ask you, and some provider pearls that might save you some time and trouble.
The typical feminizing medical regimen consists of estradiol and an anti-androgen. The estradiol produces feminizing changes, as we will discuss more about in this video. However, it is usually partnered with a medicine that either further suppresses endogenous testosterone or blocks the testosterone from acting at the receptor level. Additionally, some patients are on progesterone to further support their transition. We will talk briefly about this as well. Getting ready. Before starting estrogen, you need to get baseline lab work, which is what you will monitor throughout the course of a person's transition. Frequency will vary depending on the duration of time that a person has been on hormones. Prescribing. There are several different formulations and administration routes of estrogen, all equally effective, though anecdotally, patients may report differences. Several patient-driven factors should be considered here. Adherence, daily, weekly, biweekly. Medical comorbidities. If someone has a medical condition that puts them at higher risk, for example, of blood clots, you may want to recommend the patch. Preference, injection versus not. Environment. Does this person have stable housing, access to a safe place to store supplies, ability to safely dispose of sharps? These should all be considered. In terms of anti-androgens, there are medications that work at the receptor level, which means blocking testosterone from binding at the receptor, making it unable to have a physical effect at the tissue level. An example of this is spironolactone or finasteride. Other medications work centrally to shut down the pathway of producing testosterone. These are called GnRH agonists and also are used in puberty suppression. Progesterone is a medication that's sometimes added. There's little data to support its use, but the benefits of a trial for optimizing breast development, any libido or erectile dysfunction issues, possible sleep issues, typically outweigh the possible risks. Physical changes in timing. The medical transition process is a years-long process. That being said, most folks do report experiencing physical and emotional changes by the 3 to 6 month mark. There are many factors tied to physical changes, such as dose, genetics, and many unknowns. Side effects and management of side effects. Typical side effects that you can expect to see potentially with estradiol include increased weight, decreased libido, erectile dysfunction, some lab abnormalities that we'll talk about in a minute, pituitary adenoma, gallbladder disease, but the most worrisome one is venous thromboembolism, or VTE, and we'll talk more about that as well. So your patient has started estradiol and an anti-androgen medicine. They may be noticing some physical changes, possibly managing some side effects. What does monitoring look like? Well, for the first year, you're going to monitor more closely. In our practice, it's every 3 months. You want to assess physical and emotional well-being, check vital signs looking for perhaps hypertension or weight gain, a physical exam, and this is typically only if a patient has specific concerns, and blood work. As mentioned before, the most worrisome risk of estradiol therapy is VTE. So asking questions about signs and symptoms of blood clots should happen at every follow-up visit. Checking liver function tests, particularly if there's been weight gain, and also since estradiol is metabolized in the liver, is important. You will regularly monitor estradiol levels to ensure that you remain in the therapeutic range, ideally at the lowest possible dose, since we know that doses typically are directly related to side effects, as well as testosterone levels to monitor for suppression. If someone's on spironolactone as their anti-androgen, you'll want to check potassium and renal function regularly. As time goes on, these vitals and lab monitorings can be spaced out to every 6 to 12 months.
We've already reviewed types of gender-affirming surgeries in an earlier video. And generally speaking, surgery is outside the scope of this video series. But as we talk about feminizing regimens, it might be helpful to remind yourself of some common surgeries that might go along with a feminizing hormone regimen. So some common surgeries might be breast augmentation, vaginoplasty, which, as you'll recall, is the creation of a neovagina in place of penis and scrotum, as well as facial feminization surgery, which is the softening of the facial features to create more of a feminine contour to the face.
Provider pearls. Anecdotally, injection formulations of estradiol have led to more supertherapeutic levels. I typically start at the lower end of the dosing range because of this. If injecting, be as specific as you can on the prescription for needles and syringes. This can be confusing for all involved, the patient, the pharmacy, and you, if you are too vague. If someone has a medical comorbidity, as mentioned before, we really want to consider the estradiol patch. Extrapolated data from postmenopausal cis women on HRT with estradiol shows a significantly lower VTE risk when using the estradiol patch. If someone has a strong family history of breast cancer, offer them a hereditary oncology referral so they can make the most informed decision about their risk. A lot remains unknown, but if they are at higher risk for breast cancer, they may need different monitoring. Injection teaching is extremely important. The last thing we will want is a patient using a non-medical source to learn how to inject medication. Consider making a handout or a short video showing the proper technique.
So some frequently asked questions that you should be prepared for patients to ask you include, will I be an emotional wreck all of the time?
Possibly. Most patients report some emotional changes to varying degrees. I would say the most common thing I hear is, yeah, I'm crying a lot more. Usually it does not interfere with function, but that might be something to talk about with a mental health provider if you do have one.
Will it get rid of my facial hair?
So estradiol definitely makes the hair grow in slower, finer. It makes the skin more smooth, but it will not completely eliminate body and facial hair. Some folks elect to do electrolysis or laser hair removal, but it is certainly not something you can expect 100% with estradiol.
Stay tuned for the final video in our Building Blocks for Trans and Gender Diverse Care series, where we'll talk about preventive health care for your trans and gender diverse patients.